Good evening. Welcome to another continuous professional development session organized by the Sri Lanka College of Specialist Family Physicians. Today's session will focus on HIV and other sexually transmitted infections, mainly an update about those. So we are honored to have Dr. Piumi Pereira, consultant venereologist from the STD clinic in Puttlam, as our resource person today. Thank you, Dr. Piumi, for accepting our invitation and sharing your expertise with us today. And before we begin, I would like to remind a few housekeeping rules. Please ensure your microphones remain muted unless you want to ask any questions. And if you have any questions, it's better if you can forward those to the chat box without unmuting your mics. And kindly fill out the feedback form at the end of the session. And there will be some multiple choice questions as well in the feedback form. So make sure to answer those as well. And to obtain the certificate, CPD certificate, you must attend the session for a minimum of 45 minutes. So we hope you will find this session informative and engaging as well. So let's get started. I invite Dr. Piumi for her talk.
Thank you so much for that kind introduction. I hope you all can hear me.
Yes, madam.
Okay. Okay, you can see my slides, no? Yeah, okay. Yes, good evening, everyone. So I was asked to do an update on STD and HIV and what's happening in Sri Lanka and what as doctors that you all need to know. So I'm going to do some uh, basic update on HIV and common STDs in Sri Lanka. So this is my overview. I'll be talking about the latest epidemiology of the STIs, common presentations, and the latest HIV trends, available services, and how you as family physicians can help in the national response to the HIV epidemic. So still, Sri Lanka has a very low prevalence for HIV. It's less than 1%. However, in certain populations and age groups, the trend of HIV cases seems to be rising. And in 2022, after 22, our country experienced a notable change in epidemiology of STIs as well. And we noticed some rising trends in most of the infections. So you may have heard the National STD/AIDS Control Program is the main institution for the control of STIs and HIV in Sri Lanka. And island-wide, there are 41 STD clinics, which are mainly attached to the district hospitals. So moving on to the local epidemiology of STIs. So usually in Sri Lanka, what we mostly see are genital herpes, non-gonococcal infections, and genital warts. So those are the main STIs reported, and it has been the same for the last 2 years as well. And among females, we see more genital herpes and non-gonococcal infections. And among males, we see more genital warts, syphilis, and gonorrhea. So this is how the overall STI trends in Sri Lanka. As you can see, the blue line indicates genital herpes. So that is the highest reported STI in Sri Lanka. Then the trend of syphilis cases by stage. So usually what we see is the late syphilis infections. So usually late syphilis is the non-infectious stage. So we used to see a lot of late syphilis infections. However, during the last 2 or 3 years, we are seeing a rising trend of infectious syphilis as well. I will explain that more in the next slides. So this is how the trend of infectious syphilis has been during the last 6 or 7 years. As you can see, among males, the infectious syphilis is rising. So that means the the new infections are occurring among males, especially syphilis cases. So, if a person is if a person has syphilis, that person is more prone to acquire HIV as well uh, because of the inflammation, local inflammation, and all. So rise in infectious syphilis will lead to a rise in acquiring HIV. So that is important. And then the gonorrhea cases. Again, it has shown a rise during the past few years, especially in 2022, and we have the latest data in 2023 as well. So we've seen a notable rise in gonorrhea cases. And again, this is more seen among males. Then the non-gonococcal infections. We do not have lab facilities to detect chlamydia in the government sector at the moment. So all the urethritis or cervicitis we see without gonorrhea, we categorize them as non-gonococcal infections. So even though there was a drop in year 2020 and 2021, again the trends are rising to the levels before the COVID pandemic and the financial crisis. So these are the usually the most common STIs we see among our population. And again, genital herpes. So you can appreciate that the non-gonococcal infections are seen more among females. And again, genital herpes is also seen more among females. Genital warts, the trends seems to be coming down, and they are more seen among males. So how are STIs transmitted? So the word sexually transmitted infection, it is self-explanatory. So usually during with unsafe sexual practices, especially vaginal, oral, or anal sex without a condom, with multiple partners, can lead to one acquiring STIs. Then there are some infections which can transmit from mother to child, mainly infectious syphilis, and then HIV, and then hepatitis B, and then there can be neonatal infection. Uh, if a mother is having gonorrhea, chlamydia, trichomoniasis, and herpes, active herpes during delivery. And then STIs can be transmitted through infected blood, but that we see very rarely. So what are the common symptoms for STIs for females? So usually they come up mostly with, if they are symptomatic, they come with vaginal or anal discharge, vulval or perianal ulcers or blisters, vaginal or anal warts, and lower abdominal pain. So lower abdominal pain can be due to complications such as PID. But we have to remember that most of the females who are infected with STIs are asymptomatic. They usually don't show any of these symptoms. So therefore, even in the absence of symptoms, the person who has engaged in high-risk behaviors should get tested for the STIs. And common symptoms for males are, again, urethral or anal discharge, perianal or anal warts, penile ulcers or blisters, scrotal pain, and dysuria. All of these can be a symptom of STI. Again, many can be asymptomatic, so they might not have any of the symptoms, but they can be infected. So therefore, in the absence of symptoms, again, if you see a patient who has had high risk behaviors, it's always good to ask them to get tested for HIV. So we have a mixture of bacterial diseases as well as viral diseases. So most of the bacterial diseases such as syphilis, gonorrhea, and chlamydia can be completely cured. So if we diagnose a patient with these infections, we can completely cure the disease. But however, some diseases we cannot fully cure, but we can effectively control using medications. So these are mainly the viral infections such as HIV, genital warts, herpes, and hepatitis B. So there are lots of complications as well with STIs. So gonorrhea and chlamydia can cause PID, epididymochitis. If they are not properly treated, the patient can end up with infertility, subfertility, disseminated infections, and so on. Then syphilis can go on to tertiary syphilis, where the cardiovascular system, the CNS, and all the bones can be affected with syphilis. HPV, you all know, can cause cancers. It can be either cervical, vulval, anal, or penile. Then herpes can cause vulval adhesions, post-herpetic neuralgia, and encephalitis very rarely. Hepatitis B and C can cause cirrhosis and hepatocellular cancer. So, as I mentioned, mother-to-child transmission of gonorrhea or chlamydia can cause ophthalmia neonatorum of the neonate. And then, if it is syphilis, the baby can be infected and be diagnosed as congenital syphilis. And if the mother is having active lesions of herpes, the baby can get neonatal herpes, which can be which can have a high mortality as well. Then, apart from the physical complications, there can be mental health complications. They can be anxious, they can be very worried. Sometimes they go into depression thinking of all these STIs. And then there can be lots of relationship issues as well uh, with these patients. So, apart from managing the disease per se, there are other management issues that we need to think of. One thing is partner treatment. So, there are certain diseases that we need to treat the partner, even if the partner does not have any symptoms or any positive test results. So, I mean, we have to do this by educating our index patient and asking that patient to bring down the partners to the STD clinic. So sometimes we face issues with such management, in managing the partner. Then we usually do a comprehensive counseling. So we counsel about the disease, and then about the treatment and the natural the natural uh, how the disease will um, act long term, and then the complications. And then we also counsel on safe sex and how to prevent getting a STI in future. So, so in the STD clinics, we usually take around 30 minutes to like see a patient, counsel, and do health education and everything. So they need comprehensive counseling. Then we must make sure that their confidentiality is maintained. Otherwise, they will face a lot of issues, and as well, they won't come to our services, because if they have some fear that they will be identified, that their privacy will be breached, then they will not access our services. So we need to ensure confidentiality of our patients. Then there's this other big issue, which is stigma. It is actually two types of stigma. One is internal stigma, which the patient, he or herself, has. So when they have STI, they start stigmatizing themselves. So that is also a bit of a big problem that we have to manage. And of course, external stigma by the healthcare worker or service provider or the society. So that also uh, cause problems when we are managing our patients. And then sometimes we might have to follow them up long term, especially patients who were diagnosed with syphilis. We follow them up for at least 2 years. And then, depending on the window period, we sometimes have to repeat tests at certain after certain time periods. So we have to explain all that and educate, and then ask them to come for follow up. Otherwise, they will be lost to follow up, and there will be issues in management. So, as I mentioned, in some certain conditions, we have to treat the partner as well, even though the partner does not have any symptoms or any pathological findings. So, The following are the conditions that we usually do this epidemiological treatment. Usually, we have to treat the partner if the index patient has gonorrhea or chlamydia or trichomonas vaginalis. And then, if the patient is having infectious syphilis, again, we will have to treat the partner. Then, if we diagnose a patient with pelvic inflammatory disease or epididymocarditis, we usually think that it can be due to a STI related pathogen. So again, we will have to treat the partner. And usually we tell the patient as well as the partner not to have sex until both have completed treatment and they've undergone the necessary test of cure, so that we can ensure that they are both completely out of uh, that they don't have the pathogen themselves, so that they won't like reinfect themselves. So that is also very important when you are managing a STI patient. So moving on to HIV. Um, so now we are at the highest level of total number of PLHIV. PLHIV is people living with HIV, and around 38 million people living with HIV are uh, they are in the worldwide according to the UNAIDS. So now the number of people living with HIV are increasing, because now probably you all know, that we have antiretroviral treatment. So with the treatment, the people who have infected with HIV, they don't die of HIV. They now live with HIV. So the number of people living with HIV are rising. So a little bit details about HIV and AIDS. So those are two different entities actually. HIV is human immunodeficiency virus. It's the virus. And then once our immune system is really damaged, the person who's infected with HIV goes into AIDS. That is known as acquired immune deficiency syndrome. So this is the basic viral structure of HIV. It has an envelope, it has a core, it has RNA particles and related enzymes, which helps with its replication. And it is a retrovirus and comes under the genus lentivirus. So the features are, it has a chronic course and a long period of clinical latency. So you all know, once you get HIV, you cannot cure it. And uh, most of the time, for like 8 to 10 years, there will be no symptoms, even with the infection. And what happens is, there is persistent viral replication, and also there is involvement of the central nervous system as well. So that's why we cannot eradicate the virus, because it goes and hides in the central nervous system. So we cannot eradicate the virus from the body. So the cellular targets of HIV are mainly the CD4 T lymphocytes. So what happens is, uh, so this is what happens with HIV. So let me just use the mm, can you see my sorry, mouse pointer moving?
Yes, we can see.
Yeah, okay. So here, let's say a person got the infection at this point in time. So usually a normal healthy person will have a CD4 cell count of around 800 to 1000 or more. So when the person gets infected with HIV, then it attacks the CD4 cells. The virus goes and attacks the CD4 cells, and then our CD4 cell counts drops. But still, our immune system tries to fight the virus. So then again, the CD4 cell counts becomes to a little bit of a better level than previous. And then with time, let's say 10 to 12 years, with time, the CD4 cells fights with virus, but after some time, it cannot fight anymore. They cannot fight anymore. So then the CD4 count starts to drop drastically. So when it's less than 200 CD4 cell counts, we say it is the AIDS stage. So the lower graph shows how the viral load changes. So initially, the viral load, the red line is the viral load. Initially, after infection, there will be a peak of the virus, and here we call the seroconversion. We call it as seroconversion. So during the seroconversion, there will be a very high level of viremia, as well as the CD4 count may drop than the normal level. And after some time, because our immune system fights the virus, the immune system tries to contain the virus to some extent. So let's say for 10 to 12 years, the viral levels remain stable in our blood, but it damages the CD4. So then the CD4 drops. So after 10 to 12 years, now maybe we see this after around 8 years, because the CD4 cells drop, our immune system cannot contain the virus anymore. Again, the virus starts to replicate. So CD4 cells are very low. So we call it as the AIDS stage. During the AIDS stage, the virus is also again replicates, and it has a higher level of viral load in our body. So during the seroconversion as well as during the AIDS stage, the infectivity is very high compared to the stable phase. So that's what happens with HIV in our bodies. So these are the symptoms of seroconversion. Not everyone will have the seroconversion syndrome. Only several people, only like let's say 50% or so will have the seroconversion syndrome. So seroconversion is acquiring antibodies against HIV once the person is infected with HIV. So this is a very non-specific syndrome. There'll be fever, maculopapular rash, cough, anorexia, arthralgia, myalgia, so many non-specific symptoms associated with the seroconversion syndrome. So usually people don't even recognize it as a illness. But after some time, the infected person goes into the stage 1. So stage 1, usually, as I mentioned, they are probably asymptomatic, and only some people can get persistent generalized lymphadenopathy. So if you see a patient with lymph node enlargement for some time, it's always good to do HIV test. Then the stage 2 can have unexplained moderate weight loss, recurrent respiratory tract infections, herpes zoster, angular cheilitis, and also recurrent oral ulcerations, papillopruritic eruptions. That is very, very common. So this is the picture of papillopruritic eruptions. They usually come on bare, like, the exposed areas of the body, such as the upper limbs and lower limbs. So I mean, what they have is like after a mosquito bite, they get a very severe sort of allergic reaction. So pruritic papular eruptions. They usually go to the OPDs. They sometimes go to the dermatology clinics. They might come to the GPs as well. So if you see such skin rashes, you must do an HIV test, because we've diagnosed so many patients at this stage when they present with pruritic papular eruptions. Then if the patient is having seborrheic dermatitis or fungal nail infections, all that can be considered in HIV as well. In children, there will be extensive molluscum contagiosum infection. And in stage 3, that is after some more time, when the patient CD4 count has dropped a little bit more, they can have a severe weight loss, unexplained diarrhea, which is lasting for more than 1 month, and then unexplained persistent fever. So that is which we all know as pyrexia of unknown origin. So if you see a patient with PUO, HIV test is a must. And then persistent oral candidiasis, oral hairy leukoplakia. So this is oral hairy leukoplakia. You cannot scrape the the whitish parts. So candidiasis, you can scrape it, but OHL, you cannot scrape it. So these indicate HIV. And then there can be pulmonary TB, severe bacterial infections, acute necrotizing ulcerative stomatitis, gingivitis or periodontitis, and then unexplained cytopenias. Again, that's another common thing that we see, especially thrombocytopenias. And TB, of course. TB, if you see a patient with TB, you must check if they have undergone HIV test because it is very commonly associated. Then comes to the AIDS defining illness. So once the CD4 counts drop to less than 200, we call it as WHO clinical stage 4, which is also known as AIDS. So these are the, so usually what happens is, as the immune system is very, very damaged, all the opportunistic infection starts to give symptoms and diseases. So one of the commonest thing that we see is pneumocystis pneumonia. So they come with a chronic cough, shortness of breath. They may or may not have fever. So very, very quite non-specific, but long-lasting, and they can get easily desaturated. So if you see patients like that, HIV is a must. Then extrapulmonary TB is associated with the AIDS stage. There can be Kaposi sarcoma. This is a sort of a vascular tumor. And then CNS conditions such as toxoplasmosis, CNS lymphoma, PML, these are very commonly associated with the AIDS stage. Invasive cervical cancer, again, is an AIDS defining condition. Then HIV wasting syndrome. We usually do not see this much now because we see patients at early stages now in Sri Lanka. So, but still, we see around 16% of our patients coming in the AIDS stage. And then extrapulmonary cryptococcosis such as cryptococcal meningitis and this skin rash caused by the cryptococcosis. And esophageal candidiasis, that is another quite a common presentation. They will come with dysphagia or dinophagia and loss of appetite, loss of weight and all that. So if you see a patient with esophageal candidiasis, HIV test is a must. All these age-defining illnesses, if you see a patient, you have to make sure the patient has undergone a HIV test. Then cytomegalovirus infection, which can cause retinitis, mainly retinitis, and then there can be pneumonitis, colitis, esophagitis, and all other organ involvement as well. Then there can be chronic diarrheas with all these opportunistic infections. So then moving on to how we diagnose HIV, mainly we do a blood test. Now what we do is a rapid test, and so rapid test, the results will be given within 20 minutes. And we used to use the Western blot as the confirmatory test. Now, as the WHO guidance, we now go with the 3 rapid test algorithm. So we do 1 rapid test if it is positive, then we use 2 other rapid tests in different platforms, and depending on that, we diagnose a patient as having HIV. I will go into testing in more detail after I speak about the local epidemiology. In Sri Lanka, we estimate that there are around 4,100 people living with HIV by the end of 2022. However, only around 86% know their status, and only half of the estimated number are in our clinical services. So as you can see, there is a big gap between the estimated number and the number in the services. And what we see is a rising trend. So when we look at the past 10 years, as you can see, in 2011, it was around 144 patients, which was reported during that year. However, in 2022, this number has gone up to 607. And last year, now we have the latest data. Last year, the number is 680 plus. So somewhere almost nearing 700 patients. So you can see that the numbers are increasing. And the dotted blue line depicts the male patients. As you can see, the females have been stable throughout the years, the number of females who are reported annually with HIV, but the number reported among males has risen with time. So 86% of the patients who were reported to us during 2022 were males. And this is actually a quite an alarming trend, because the number among young people, especially the 15 to 24 years of age, so they may be schooling, they may be starting universities, they may be just starting a job, that population, especially the males, young males, among them, we see a rising trend, even though the numbers are small. The number is 73, 73, but the trend is alarming. That means among the young population, young male population, HIV is reported more during the past few years. And this is another new, I mean, not new, but a trend that we've noticed for the last couple of years. So the probable mode of transmission among the persons who were diagnosed with HIV, the, the, the most common mode of transmission was male to male sex. So that's why we've noticed that among especially young males and male population, the HIV trend is rising. Moving on to HIV testing. So as I mentioned, we now do the rapid test. However, uh, there are several methods, modalities, and settings of HIV testing. So the patient can come to our services and come for voluntary counseling and testing. Or what we actually do is, what you can actually do is provide initiated counseling and testing. You can initiate this. If you see a patient with a high risk, like let's say if a patient known to you comes to you and say that he has undergone some sort of high risk sexual behavior, you can initiate testing. And if you see a patient with all these symptoms, signs, and all these disease conditions, again, if the doctor initiated testing, then it is known as providing initiated counseling and testing. So actually, now you don't have to do a very big, thorough pre-test counseling. You can just educate them. I'm doing an HIV test because you are having some sort of symptoms. So it's always good to know your status. So actually, that is enough, because now we have treatment. So once you do the pre-test, once you give the pre-test information, if it is positive, then you can send the patient to our clinics. So we will do thorough counseling. So the settings are usually at the STD clinics. We do outreach testing, and you all know antenatal mothers. All the antenatal mothers undergo pregnancy testing for HIV and syphilis, and then all TB patients have need to undergo HIV testing. Then blood donor testing is done. Hospital-based testing, especially if the patients are symptomatic. Then visa screening. And then there's this new modality, which is the HIV self-test. I will explain about it a little bit. So as I mentioned, we have this 3 rapid test algorithm. So the rapid test usually takes around 20 minutes. If one test is positive, then we do another 2 tests. And depending on that, we will diagnose the patient. And then there's this self-test. So this is the picture of the self-test. I hope you can see my pointer. So the self-test, the patient can do it by themselves. They can order the test online, and so then we courier the test to their whatever the address given. So this is done using oral fluid from the gums. So sensitivity wise, it's quite good. It's around 93% sensitivity, and it's quite specific as well. So it's very easy for them to do it. No need to involve blood. And so especially the patients people who does not want to come to STD clinics, who are anxious to come, they actually order test kits from our virtual platforms, and they do it by themselves. So our virtual platform is known as knowforsure.lk. So I have taken all these pictures from our website. So this knowforsure.lk provides many services. A person can sort of assess their risk and book appointment at a STD clinic, or order a test kit, or even chat with a healthcare provider and get advice. So it is actually a very good virtual platform. And with that, we've reached many hard to reach populations in Sri Lanka. And then, as you all know, antenatal screening has to be done in the first trimester so that we can identify pregnant mothers who are having HIV, and then we can give them treatment so that the baby will not get the infection. Moving on to HIV treatment. So since the first reported case of HIV in 1981, there have been so many drug regimes, so many new drugs uh, so far, and now the HIV treatment has become very, very effective, and that's why our patients are now living uh, as a normal person, and up to living with um, to their normal potential age. So what we do now is, whenever we diagnose a patient, we treat them all. So we don't wait for the CD4 to drop. We don't wait for any other thing. If we diagnose a patient, if the patient does not have any CNS symptoms, we treat that patient preferably on the same day. So what we use is a 3-drug combination. And the first line, I've just mentioned these medications. If you see a patient, you can just check if the patient is on these drugs. So the first line in Sri Lanka is tenofovir disoproxil fumarate, emtricitabine, and dolutegravir. So it's a 3-drug combination. We actually have many more drug combinations, but depending on the situation, we sometimes change the drug regime. But this is the first line that we start for all our patients. So if you diagnose a HIV patient, the best thing is to liaise with a consultant venereologist, and so that we can offer them comprehensive counseling and all these treatment options. There can be common side effects as well. However, I mean, compared to the previous drug regimes, the side effects are very, very minimal, but still there can be side effects. So tenofovir can be associated with nephropathy and bone mineral density loss. Dolutegravir is related with weight gain and drug-induced liver impairment. Then there can be common GI symptoms as well, which are quite self-limiting after some time. So this is the commonly seen side effect with this first-line regime, tenofovir associated nephropathy. So usually it's a proximal tubular nephropathy. So what we do is we monitor the patients with UFR looking for albumin, and then we also check the serum creatinine and measure their EGFR. And depending on the EGFR and presence of proteinuria, we might have to change the regime to an alternative ART regime. And there can be common drug interactions as well. So we have to be cautious when we are administering tenofovir with other nephrotoxic drugs, because it can anyway cause a nephropathy in PLHIV. And then some of our patients are with TB co-infection, so they will be on rifampicin. So sometimes we have to, if the patient is on rifampicin, we have to double the dose of dolutegravir. Otherwise, the drug, the plasma concentration will not be enough to control the HIV virus. And then antacids reduce dolutegravir levels. So if the patient is taking antacids, then it has to be spaced out, and sort of they should not take dolutegravir and antacid together at the same time. So if you want to check for drug-drug interactions, you can just Google the HIV Liverpool drug interaction website, and you can just enter all the HIV treatment and the other co-administrating medications, and then they will give you all the potential interactions and what to do very comprehensively from that website. So this is the newest concept actually. Undetectable equals untransmittable. So as I mentioned, uh, when we give treatment, what happens is the treatment contains the virus. It suppresses the virus to an undetectable level. So once the patient is on treatment, and if we do the viral load, the load will be undetectable in the test. So once the patient is undetectable, that means he is fully virally suppressed, he cannot transmit the virus to another person through sexual intercourse. So that is actually a very groundbreaking finding, because uh, now they can, I mean, of course, they are living as the same, I mean, similar to a normal person with antiretroviral treatment. At the same time, they cannot transmit it to another person. So this has changed a lot for their, I mean, stigma wise, their empowerment wise, everything has been changed because of this finding. This is the same concept that we use for antenatal mothers. So if we diagnose antenatal mother with HIV and we start them on treatment, and once their virus is undetectable, then the baby will be HIV negative. The risk of transmission to the baby will be minimal. So uh, this is actually a very important concept. Undetectable equals untransmittable. So once they are undetectable, they cannot transmit it to another person. A bit about HIV prevention. So you all know the usual methods: safe sex, condoms and lubricants. So those are the traditional ways of HIV prevention. Now we have newer methods such as pre-exposure prophylaxis and then post-exposure prophylaxis, which can be either for occupational exposures or non-occupational exposures. And then treatment as prevention. As I mentioned, U equals U. So if you take treatment, you cannot transmit it to someone else. So we treat for the benefit of the patient per se, as well as treatment as prevention, for because we can break forward transmission if the virus is undetectable. Uh, I forgot to mention that treatment is lifelong. Once the patient is on treatment, the patient has to take the medication until the end of his life, because we are just controlling the virus. We cannot cure the virus. As long as the treatment is taken, the virus will be controlled. But as soon as the patient does not take the medication, the virus starts replicating. Then active management of HIV in pregnancy. So that's how we prevent mother to child transmission, by treating the mother with antiretrovirals and sometimes opting for planned cesarean sections, and then formula feeding if necessary, depending on the viral loads. Then a bit about PrEP. This is called pre-exposure prophylaxis, and this is offered to key populations in Sri Lanka, especially males who have sex with males, transgender women, intravenous drug users, and sometimes serodiscordant HIV couples, where the HIV positive person's viral load is not suppressed. So this pre-exposure prophylaxis can be taken as oral tablets, or even though it is not available in Sri Lanka, in other countries, long-acting injectables are available as PrEP. So oral PrEP they can take it as a daily tablet or event-based tablet. And long-acting injectables, the benefit is that they can take it once a month as a sort of a depot injection, and then it will give, uh, it will, like it will be safe for them to have unprotected sex if they are taking pre-exposure prophylaxis. Then post-exposure prophylaxis, that is given after exposure. So usually what you must know is even after occupational exposure, post-exposure prophylaxis has to be taken within 72 hours of the exposure. So starting it as soon as possible is the best, but if not, it has to be started within 72 hours. After 72 hours, the effect of the treatment is not there. So that is why that this window is very important. So PEP-C, that is post-exposure prophylaxis following sexual exposure, can be offered following, let's say, sexual abuse or even a high-risk sexual exposure. So once we start this treatment, they have to take it for 28 days for it to be effective. So this is just to let you all know the achievements that Sri Lanka has received. So Sri Lanka has obtained the World Health Organization certificate for elimination of mother-to-child transmission of HIV and syphilis in 2019. So, and then we are having a revalidation at the end of this year. So we hope that they will be satisfied with our program performance. So if you see a patient who has undergone a stillbirth or a miscarriage and they have not undergone HIV test, then please do a HIV test, because even a stillbirth or miscarriage can be due to HIV infection. So our targets are ending AIDS epidemic by 2030 as a public health problem. So what you all can do as family physicians is identify these HIV indicator conditions or AIDS defining conditions at your settings and offer HIV testing. So as I mentioned, you don't need to do a very thorough pre-test counseling. You can just give some information. And as you offer a full blood count, you can offer a HIV test saying, I'm going to do a HIV test because I need to find out whether there's any issue, because sometimes this can come with that infection as well. So no need to like scare the patient, but just offer it. And then it's usually a rapid test. And even the rapid tests, we had this program where the GPs can keep the rapid test at their GP practices. So it is actually a finger prick. So they can do it using a finger prick blood. So very easy. So it is a point of care test. So if you need, we can arrange that as well. So what you have to know is how to identify these HIV indicator conditions and AIDS defining conditions and offer a HIV test. And if you see any antenatal mothers, make sure that they've all undergone their HIV test in the first trimester. And if necessary, and if you think that this patient can be high risk or the patient's partner can be having high risk behaviors, it's always good to repeat the test at the third trimester as well. Then it's important as doctors to be aware about the availability of the post-exposure prophylaxis and the need to start it within 72 hours of exposure. And of course, reducing stigma and discrimination is very important. Otherwise, all these marginalized and key populations, they go into hiding. They might not come to our services, but they won't change their behaviors. So with that, even though they don't come to the services, they will be getting infected, they will be transmitting. So the society will be at risk. So we must, eliminate stigma. We have to have a zero stigma policy so that they will come to the clinics, they will retain in the clinics, and they will take treatment So uh, further transmission is stopped. So as I mentioned, our goal is to end AIDS epidemic by 2030. So these are some of the websites that you can use. So the first one, the top one is the National STD/AIDS Control Program website. So you can see there are several tabs. Under statistics, you can see all our statistics, the yearly statistics, quarterly statistics, and all that. Under resources, we have our annual reports, guidelines, policies, strategies, and everything. So anything you can these resources are very very rich. You can use them if you need, especially the guidelines, and see uh, it will help you with STI management at your setting as well. And then this is the Know for Sure website. Here a client can assess their risk for HIV, and they can book a safe, confidential, and anonymous HIV test, as well as book an appointment in the STD clinics. So these websites you can either introduce to your clients, or you can even use these resources for your practice as well. So that's it for my lecture today, and I've jotted down my contact details. So I'm happy to answer any questions if you have. Thank you so much. Should I go on to the chat and answer, or will somebody moderate this? Or okay, so there's this question. What are we looking for in rapid test and Western blot, both HIV 1 and 2 antigen and antibody? Yes. So in the rapid test that we have, we check for both HIV type 1 and type 2, antigen plus antibodies. So it's a fourth generation rapid test. So the sensitivities are high, as well as the window period is narrow. Western blot, we only check for the antibodies. So it's a third generation test. Then the next one is detection of P24 antigen is earliest to be positive. Yes, so P24 antigen is the earliest. No, it's not actually the earliest one. Viral load will be the earliest one to detect. So usually viral load we can detect within 7 days. P24 might take around 2 weeks. And then and antibodies can be negative up to 3 months. So that's what we called as the window period. The earliest detecting particle is the viral particle. So it will be like it will take around 7 days for the virus to appear in the blood. What about post-exposure testing? Yes, post-exposure testing, what we actually do is, I could not go into detail because it's just a 1 hour lecture. So what we do is we must check if it is an occupational injury, we must check the source blood. That is, if you know the patient that you got the needle prick or the mucosal splash from, that person's blood has to be tested. And at the same time, we test the healthcare workers' baseline HIV test as well. And depending on that, we either give post-exposure prophylaxis or we counsel the healthcare worker. And later on, we will, if we start anyway, we will do the healthcare workers HIV test at 6 weeks and 12 weeks from the exposure. So we explain and we ask them to come to the STD clinics during certain times so that we can retest. Can we call any STD clinic to get down the self-test kit? Yes, most of the STD clinics do have the self-test kit. So especially you can use the virtual platform knowforsure.lk and you can get down self-test kits. But do we test in rapid test? So as I mentioned, it's an antigen antibody for HIV 1 and 2. Okay, so this one they've asked in the management plan, partner treatment, what about the confidentiality? If the patient do not like to breach. So yes, that's an actually an issue, but our responsibility is to the index patient. So we have to counsel the patient, the person who has come to us about the need for treatment, need for partner testing and treatment. And if the partner has not undergone treatment, the risk of the index patient getting reinfection. So with education and counseling, they usually bring their partners for testing as well as for treatment. So we tell them that we will discuss things with the partner and what they want us to say. Usually the patient decides that he or she will tell the partner that about this, whatever the disease that they have and the need for treatment. So once they have discussed with the partner, then we can go ahead and inform the partners. But without the patient's um consent, we cannot go directly to the partners and inform them because our responsibility is to the index patient. I hope that is clear. Then, what is the advised testing method for needle prick injuries and post-exposure prophylaxis? So now what we do is the rapid test because the sensitivities are very high. So we usually do the HIV antigen antibody rapid test. What is the place of GP120 test in Sri Lanka? So usually that was available in the Western blot. So for the screening, we don't use the GP120 test. Um, During treatment, is it indicated to do routine CD4 count? Yes. Baseline, we anyway have to do the CD4 counts because depending on the CD4 level, we will have to think of starting prophylaxis like cotrimoxazole prophylaxis or MAC prophylaxis and things like that. And also, once they are out of danger, that is, once their CD4 count is more than 200 or 350, we can stop all this prophylaxis. So during that time, we usually do routine CD4 counts. If the patient's CD4 count is more than 500 and the patient is on treatment and the viral load is suppressed, then we don't have to do routine CD4 counts. Patients who are on PrEP, how should we check for HIV? So it's the same. So before we start PrEP, we do the baseline HIV test with a rapid test, and we test them every 3 months or so with the rapid test. And if they say that they've had a high risk exposure and they've not taken proper PrEP properly, then depending on the window period, we will have to retest them for HIV. Um, this person has asked, what about viral load? What does viral load say about the management? So actually, we use the viral load to see how well they are doing, to see if the treatment is working. So once they are started on ART, the viral load will come down to undetectable levels. So once it is undetectable, that means the disease progression is stopped. So that means we are managing them well. So viral load is actually very important in the follow-up of these patients. So this question, what vaccines are excluded from national immunization schedule for children who found to be positive? So usually if the child is positive and CD4 count is less than 200, we usually don't give live vaccines until their CD4 counts have caught up to the normal levels and their virus is undetectable with treatment. We usually defer live vaccines if the child is positive. What is the window period for rapid test? Because as it is a antigen antibody test, the window period is usually 2 weeks, 2 to 6 weeks. If after 6 weeks, if it is negative, usually we can say the patient is negative. How do we monitor during treatment? Yes, it is with the viral load. Um, Antigen can be positive for any time of the course of the infection. No, actually, antigen is positive early in the infection as well as at the AIDS stage because the viral replication is very high during the seroconversion and during AIDS stage. So, usually we detect the antigen at the very early stage or at the very late stage. So, this person has asked what's the efficacy of 28-day post-exposure prophylaxis treatment. So it's very effective, more than 95%. Can the person get HIV despite the treatment? Yes, if that person has not started within 72 hours, if the window has gone beyond 72 hours for initiating treatment, there is a risk of HIV even though the person has started the treatment. Other than that, the risk is very minimal. Is barrier methods 100% prevent HIV? If it is used correctly and consistently, the barrier methods are very effective in prevention. Uh, how long have to wait a patient to donate blood after post-exposure prophylaxis? So usually we say the last HIV test will be done at 3 months. So if that is also negative, then we can clearly say that the patient does not have HIV. Uh, what can we do for a patient in window period to repeat after 6 weeks? Yes, you can assess their exposure. And if you think that the patient is in the window period, you can ask the patient to retest after, if it is antigen antibody test, you can ask them to repeat it after 6 weeks from the exposure. And prophylaxis can be stopped if the CD4 count is more than 350. So those are the questions I can see. Any more questions?
Excuse me, madam.
Yes.
Madam, we have heard that shingles cause post-herpetic neuralgia.
Yeah.
Madam, the HSV 102 can cause post-herpetic neuralgia?
Yes, they can. HSV2 especially. If it is in the genital area, they can get post-herpetic neuralgia.
Okay, madam, thank you.
Any more? Okay, then. Thank you so much for inviting me.
There are two more questions appearing actually.
Is that so? Okay.
What are the
Uh,
waiting periods for other tests other than rapid tests?
yeah, so as I mentioned, so antigen antibody, it can be either rapid or ELISA. So for those tests, the window period is around 6 weeks. And if the test contains only antibodies, such as the Western blot or the generation HIV test, then the window period can go up to 3 months. And for the viral load, the window period is around 7 days.
Okay. IRI is common with?
Yeah, so IRIS, that is the immune reconstitution inflammatory syndrome. So so what happens is, let's say we see a patient with TB and HIV, and then we start the patient on ART. What happens is sometimes the TB can get worsened. So that we call as paradoxical iris. We expect the symptoms to go down, but with the immune so immunity is getting better with ART. So with the immune reconstitution, there'll be an inflammatory response. So with that, the patient can deteriorate. So that is called iris. So it is not common, but we sometimes see in certain conditions especially TB meningitis, cryptococcal meningitis, especially CNS ones, and sometimes TB lymphadenitis. In such situations, the symptoms can worsen with ART, but it is not a very life-threatening one unless it's a CNS infection. So it can cause ART can cause iris, but then we will have to manage it with steroids and all the symptomatic relief. And depending on the severity, we might have to stop ART and restart later on. So again, similar question, what is the gap between TB treatment and ART to prevent iris? So usually, if it is pulmonary TB and the CD4 count is very low, what we say is to start at least within 2 weeks. You start ATT first, and then within the next 2 weeks, you have to start ART. But if it is TB meningitis, we might have to wait around 8 weeks until the TB meningitis is the induction of TB treatment of TB meningitis is completed, so that iris is minimal. What do we have to do in iris? Stop anti-TB. It depends. If it is a very minimal iris, we can give steroids and reduce the inflammation. But if it is a very severe iris, we might have to stop all the treatment and manage them symptomatically and then restart.
Dear Madam, on behalf of the Sri Lanka College of Specialist Family Physicians, I extend my heartfelt gratitude to you for conducting today's CPD session. Actually, your expertise, your experience and knowledge on HIV and other STIs were incredibly useful for us, and I believe all the participants learnt a lot today. And I also thank all the participants, all the attendees, for your active participation and enthusiasm throughout the session you maintained until the end. And to obtain your certificate, please fill out the Google form which is provided in the chat box. And we look forward to seeing you all at our next CPD session next month. Until then, I wish you warm regards and good night.